Hello, everyone. We have a large group here today. This is, I'm Arno Kumigai, the Vice Chair for Education for the Department of Medicine, and wanted to welcome you to Citywide Medical Grand Rounds. This is a special Citywide Medical Grand Rounds that features the FM Hill Lecture. And I'm going to turn the mic and the moderation over to Dr. Paula Harvey, the Physician-in-Chief at Women's College Hospital that hosts the rounds, for her to introduce this year's awardee and the lecture. So thank you, and Paula, take it away, please.
Thanks, Arno. So I just want to start by telling people about the FM Hill Lectureship. So this year, as has become the tradition, we've asked the Women's College Hospital Dr. F. Margaret Hill, or F. Peggy Hill, annual invited lecture to be given as Citywide Grand Rounds. This lectureship is held annually to honour an exceptional physician, mentor and teacher, and the former Physician-in-Chief of Medicine at Women's College Hospital, Dr. Peggy Hill, who passed away in 2012 at the mature age of 93 years. For 27 years, Dr. Hill practiced at Women's College as a teacher, clinician and researcher. When she retired, many of her friends, her colleagues and her patients established an endowment in her name. And through their generosity, we were able to grow that fund and enable the establishment of 3 endowed chairs. So there's the FM Hill Chair in Academic Women's Medicine, the FM Hill Chair in Health System Solutions, and the FM Hill Chair in Humanism Education. It also supports this annual lectureship in medicine, plus 2 important resident awards, one for mentoring and one for humanitarianism. Leora Branfield-Day, who was our previous amazing Chief Medical Resident and is present for the lectureship today, was the recipient of the FM Hill Mentoring Award. And Susan Tran, who unfortunately is not able to attend today, was the recipient of the FM Hill Humanitarian Award. So this year, I'm really pleased that we have invited Dr. Paula Rochon to be one of our lecturers. She's one of the member of our faculty, and it's a huge honor to have Paula presenting on her life's work for us today. To tell you a little bit about Dr. Rochon, she's a geriatrician and she's a Vice President of Research at Women's College Hospital. She's a professor in the Department of Medicine at the U of T, a senior scientist at Women's College Research Institute, and she's also the inaugural RTOERO Chair, previously known as the Retired Teacher Organisation Chair in Geriatric Medicine at U of T. She received her undergraduate degree at McMaster University and her Master's in Public Health from Harvard University School of Public Health. Dr. Rochon's research focus is on understanding the unique needs of older adults, particularly older women, and she promotes their health and wellness. She's contributed to our understanding of aging and its impact both on individual patients and the healthcare system. These contributions include highlighting the need to consider sex, gender and age in research so that the results are more relevant to older women and men, and also tailoring the prescribing strategies to reduce adverse drug events in older people. She has a really strong record of federal funding and has published close to 300 papers in peer-reviewed journals, primarily related to aging. She's received many research distinctions, including being elected to the Canadian Academy of Health Sciences, and was also awarded the Eaton Clinical Researcher of the Year Award for 2020. So it's with great pleasure that I introduce Dr. Rochon as this year's FM Hill Lecturer. The title of Dr. Rochon's talk is Shifting the Focus, Increasing the Visibility of Older Women in Clinical Research and Care. So over to you, Dr. Rochon.
So thank you very much, Paula, for that lovely introduction. I'm really delighted to give the FM Hill lecture today. When I was thinking back on this, the first time I ever came to Women's was for an event, and it was the FM Hill lecture. And actually, I got to meet Dr. Hill in person then. So it's particularly then special for me to be able to give this lecture. So I'd like to start by talking about what we're going to do today. So I want to describe a little bit about what aging looks like and what some of the inequities are that exist for women. And then think a little bit about why older women need to be looked at separately. And I think we'll realize through this how sex, gender, and age considerations translate into improved health and wellness. So that's what we'd like to do today. So I'm going to start out and with talking about me. So I was one of these people that always knew I wanted to be a doctor. And I remember writing in my scribbler, my notebook, when I was really quite young, I want to be a doctor. And at the same time, I also wrote, I don't want to be a dentist. And I think that sentiment has kind of stayed with me. And although my path was clear, it really wasn't clear to me what kind of doctor I wanted to be or what kind of medicine I wanted to pursue. And it really wasn't until quite late in my medical training that geriatric medicine was even something that was brought to my attention as a possibility. And it was Michael Gordon, who is Canada's first geriatrician, who actually really, I think, is responsible for introducing me to the idea of geriatric medicine, because this was a specialty that really just was not on my radar. Now, around that same time, I was starting to pay attention to the health of my grandparents. My grandfather actually lived to almost 103, and my grandmother lived well into her 90s. But I just was starting to become aware that not all older adults lived those same kinds of active and long lives as my grandparents did. And it sort of seemed to me that there was really a gap in our ability to care for older adults. And this was exacerbated by a research gap. And this equity gap is really what inspired my career, both as a geriatrician, as a researcher, and the focus that I've really had and developed over time on older women. Now, when we look around our society today, I think it's never been more clear that there is a need for health equity for older adults, and it's greater today than I think it's ever really been. So soon Canada will be what's called a super age society, where 20% of our population is going to be over the age of 65. And by way of comparison, the number of young people, those under the age of 14, are really declining. And they now represent only about 16% of the population. Now, despite those numbers, it's interesting to look at, geriatricians. So in Canada today, we have about 304 geriatricians. I'm one of them, and that's not really very many. It means that there's one for every about 20,000 older adults. And in comparison, there's about 9 times as many pediatricians for actually a smaller group, which doesn't feel quite right. And this health gap, I think, really disproportionately impacts older women because they increase with age. And when you get to centenarians, it's mostly women. Yet I think it's fair to say that women are just not really visible. They're really flying under the radar of many of us. Now, if we're going to talk today about older women, I think it's probably important to define what do we mean by the word old. So interestingly, the WHO has come up with a definition, and they define old as 50 years of age or older. And I think if we were to use that definition, many people listening on this call would be in that category. Probably the definition that we use more frequently is 65 years of age or older, and that's probably one that we're more familiar with. But it might be something that's a bit more relative. Simply, is it an age that's older than you? might be the way that many people think of it. Whatever it is, as a geriatrician, I think it's many different things, but certainly the ages that are put forward, I think, no longer reflect what we mean by old in our population. So let's take a little bit of a look at some of the demographic information as it relates to older women. So if you look at the top in the big bar there, you see people over the age of 65, and you can see that about 54% of them are women. But if you move down and you look at, for example, the 85 to 99-year-old age group, it's now 64% of that group that are women. And when you get to people over the age of 100, it's actually 83% of that group. So you see, as you get into the older age groups, there's more and more women. So let's take a little look at some of the environmental factors related to women. So most older women are living in their homes, and they're very active, they're engaged politically, socially. But I think it's fair to say that women face some unique circumstances that actually can impact their health. For example, they're more likely to be caregivers, whether it's paid or unpaid caregivers. And they're also more likely to live alone, maybe in part because older women often outlive a spouse. But what this might mean is when they need care, there may not be someone there to look after them. And this, in part, explains their overrepresentation in the long-term care setting. So let's look a little bit about living alone and what this looks like in Canada, because I think these numbers are kind of striking. Around, among the 6.5 million older people in Canada right now, so those over the age of 65, 1 in 4 live alone, but there's twice as many women as men who are living alone. And among those women living alone, 40% of them say that they describe themselves as being lonely. And this is important because loneliness is something that really does impact health. And this does translate into a pretty big number, 386,000 older women who are living alone and describing themselves as lonely today in Canada. So this is an important issue, and one of our postdoctoral fellows, Dr. Rachel Savage, who is actually looking at how this impacts health, so a very important piece of work. Now let's look at some of the unique health needs of older women. So they're certainly more likely to live with chronic conditions and have multiple chronic conditions. And they also have different chronic conditions than men, more likely to have conditions like migraine, and I know that was a subject of one of our rounds just recently. Thyroid conditions and conditions like arthritis are more common in women than in men. And they're more likely to be prescribed medicines that are thought to be potentially inappropriate. And maybe related to that, they're more likely to have drug-related side effects. So it is really important to focus on older women to help us think about how do we promote health and well-being. But despite this, as I say, I think there really are the invisible majority in both research and also in the care that we provide. So I was thinking back to some of my early work, and as Paula mentioned, this is a bit of a time to reflect on some of those pieces. And one of the very first studies that I led and worked on with a team of other people related to looking at arthritis. Now, this actually came out of a class assignment when I was doing my master's in public health. And as it turned out, the professor that we had was Dr. Thomas Chalmers, who was really one of the founders of meta-analysis in the United States, and he was leading this class. So one of the assignments was we were to sort of do a bit of a meta-analysis with studies. I remember quite clearly, he came with literally boxes, file folders in boxes of all of the published clinical trials for arthritis therapies, and kind of gave it to us to work with. And I remember using these studies to start exploring how older people were included in these clinical trials. That was my question that I wanted to get out of this. And what we found was that despite older women as being the vast majority of people to have arthritis, almost none of these trials included older adults. So to be more specific, we were able to identify about 10,000 older people in these studies, but only about 14 of them could be identified as being between the ages of 75 and 84. And we couldn't identify anyone over the age of 85. And we couldn't look specifically in terms of women and men. So I think this simple study really points out, an issue that continues. It demonstrates a mismatch between who has a condition and who's actually being studied. And that will lead to treatments that are probably not appropriate for older people and not appropriate for older women. I also reflect back to one of the earliest pieces we wrote, which was an update on what's new in geriatric medicine that we did literally decades ago. And looking back on it, the title was, The Age of Women. And the opening line was, when one thinks of geriatric medicine, it's hard not to think about women. So clearly something that's been on our minds for some time. And then I think this early interest in older women is also apparent in an issue that came out of the British Medical Journal, their aging theme issue that I contributed to. And in this instance, over 100 medical journals from around the world, from 30 different countries, all came together to each publish an issue that was about aging at the same time. And I think this was really a turning point for aging in geriatric medicine, because it really recognized the importance of aging. And the cover for the BMJ's issue featured David Hockney's painting of his mother. And so I thought that was a fitting way to recognize the importance of older women when we think about aging. Now, when I think about work that we've done, clearly my experience in my first job, my 16 years of experience as a geriatrician caring for frail older people in long-term care, who were mostly women, I think profoundly influenced my thinking on the importance of studying older women. And it was actually, I guess, interesting that it was Michael Gordon who first introduced me to the idea of geriatric medicine, that hired me for that first job. And the work that came out of that largely focused on preventing medication harm, which became increasingly apparent to me that it was so important for older women because of their increased risk for drug side effects. I think it's also really important to reflect here that all of the work that we've done has been done as part of a team with amazing trainees and collaborators working with us, both locally and nationally and internationally. And so that's what's made the work, I think, good and to reflect a lot of diverse perspectives. And so they've been incredibly invaluable. But I do remember when I started out, there wasn't really a huge interest in studying older people. And I think it's fair to say that that's really changed. So during that time when I was looking after older women on a regular basis, it uncovered a lot of things that really influenced my later thinking. So I'll talk a little bit about the practice of pill splitting, issues related to antipsychotic use and their harm, and the prescribing cascade framework. Came a lot out of some of these experiences. So as a geriatrician early in my role, I noticed that the patients that I was looking after and the meds that I would prescribe for them, weren't really sort of sync, shall we say. So I would be prescribing medicines at lower doses, but often my patients had to have those doses split because that low dose really wasn't available. And, in geriatric medicine, you always do start low, go slow. And so that's what we were doing. But I started to wonder if it was just me, the way I was prescribing, or was this a much more widespread problem? So we conducted a study to look at pill splitting in the long-term care home setting. So this study was led by some amazing undergraduate students. And it was pretty simple. Like what we did is we evaluated all of the 370 residents. Almost 80% of them were women, and the average age was close to 90. And what we found was that a third of them received at least one split pill, and 16% receiving 2 or more split pills on a regular basis. And this is important because many older people are having to split their medicines and could end up taking the wrong amounts because that dose that's right for them isn't really manufactured. And that was an issue. And it was also important because the kinds of drugs that were most commonly split were medications that were being used for heart disease and for mental health issues, where probably getting the right dose is important. So we then took this idea and we wanted to look at how this relates to the provincial level. And so we decided to look at one drug. It was a drug that is widely used, and it was a diuretic that's usually used for the management of high blood pressure. And again, this was a situation where lower doses are suggested for older adults. We were able to identify about 120,000 older people who were prescribed the diuretic, and we found out that a quarter of them were having to split their pills to get the dose that was being prescribed to them. And as I say, the guidelines recommended these lower doses, but the pills weren't manufactured that way. And then this issue, I think, translates into an even bigger issue. And that relates to appropriate dosing of pills, and also looking at the differences between women and men. So as I told you, in the long-term care setting, I was particularly looking at women where maybe lower doses are more appropriate. So this situation on maybe more the world stage has been illustrated by the drug zolpidem, which is a sleeping aid. And it's an important drug because more than 10 million prescriptions are given out for this in the United States each year, primarily to women. And after that drug being on the market for over 20 years, data came forward that the risk of being drowsy the next morning and drowsy enough to interfere with your ability to drive was greater in women than men. And it was determined that women are metabolizing the drug differently. And so that needed to be taken into account when we think of the levels. So zolpidem is now one of the very few drugs where dosage is different for women and men. And as a result of that data coming forward, the FDA recommended that the dosage be cut in half. And so now there's a dose for men and a dose for women. That's half the dose. But this is only one pill, and this probably relates to many. Another piece early in my career that we noticed was we noticed problems with the newer antipsychotic drug therapies. And these were being widely used, especially in long-term care, to manage behavioral problems associated with dementia. And the thinking was that these drugs were safer than the older typical antipsychotics. And they are important, especially for women, because as you know, dementia increases with age and is more common in older women than men. And older women, therefore, are likely to be getting these medications. So we were concerned that the side effects from these drugs were putting older people, particularly women, at risk for serious harm. And we were starting to see that in our clinical practice. So we conducted a series of studies to look at this potential harm. So one of these studies was led by Dr. Sudeep Gill, who was a resident, I believe, at the time, working with us. And we were able to look at something like 27,000 older adults who were living with dementia in Ontario. And we were able to compare the risk for death with these newer atypical antipsychotic drugs to the older typical antipsychotic drugs. And these use of the newer drugs, we found, was associated with increased mortality compared to not using an antipsychotic drug. And maybe, as we might have expected, the risk of death was even greater amongst the older version of these drugs, the typical antipsychotics. And this work was important because it was cited by the FDA in one of their black box warnings that linked the use of antipsychotics to death. And it contributed to the recognition of the harms associated with these drugs that I think later on was able to help reduce the use of antipsychotics when they're used inappropriately in long-term care settings, really across the country and internationally. Now, as you can imagine, when we saw these important side effects associated with antipsychotic therapy, we were concerned. And we were also concerned because we knew these drugs were being widely prescribed in long-term care, particularly across the province and mostly to women. So we did what I think was an interesting study where we looked at the variation in the use of these drugs in different long-term care homes. And we did this by looking at the prescribing rates in each of these homes and dividing the homes into quintiles based on their prescribing. So we had homes with very low antipsychotic prescribing rates in the bottom quintile, and then those with very high prescribing rates in the top quintile. And overall, we found that a third of long-term care residents, who were mostly women, were being prescribed these drugs, but there was a lot of variation in the prescribing. So homes in that lower quintile, or quintile 1, had about a 20% rate of prescribing, whereas those in the high prescribing homes in the top quintile had more than 44% of their residents getting these drugs. And the interesting part was the residents looked very similar. They didn't look different, but there was a lot of variation that we were seeing there. And I think this is important because what it sort of meant is if you happen to be a resident in a home where they had high antipsychotic prescribing, you were 3 times more likely to get one of these drugs that was potentially harmful, irrespective of your clinical situation. And we talked about this being related to the culture in the long-term care homes and maybe the quality of care and not necessarily to clinical need. And this variation that we saw amongst long-term care homes, I think is something that's really important, something that we need to think about today, especially when we're thinking about COVID-19, which we'll talk about in a little bit. So one of the other pieces that we saw first when we were looking after many older women is we saw what we have gone on to describe as the prescribing cascade. Now this occurs when a drug therapy is prescribed, side effects develop, and more medicines are prescribed to treat the side effects because those side effects were not recognized as being related to that medication. And this puts people at risk for even further side effects and further problems. Kind of a simple complex or concept, but one that I think is quite important. So I remember a couple of cases really clearly that helped us think about this concept. So one of these was an older woman we were asked to see who had recurrent episodes of very painful gout. And after reviewing her medicines, it seemed that her gout was being triggered by the initiation of a diuretic therapy, so like a water pill, to treat what was pretty mild leg swelling, leg edema. So by identifying this prescribing cascade, we were able to stop the diuretic and we were able to prevent these future episodes of gout, which is so very painful. And it was interesting that this sequence of events is often not recognized because it develops in weeks to months, not recognized as being related to a drug. It's not what you would expect as a drug side effect. And it's often confused or maybe dismissed as being related to age, and so maybe not given the attention that it warrants. But I think you'll agree with me that if you look, you will find it. And so it's something that's really important. You know, over time, we expanded this concept to move from a prescribed drug leading to more prescribed medicines to recognize that often what would happen is a drug would be prescribed, a problem would develop, and people would treat it themselves and go to the pharmacy and and getting over-the-counter medicine. And that was potentially also an issue. And we also noted that a drug could also lead to the use of a medical device, which is something that we've talked about more recently. So this also is something that comes from some clinical experiences. So I remember early we were asked to do a preoperative consult for an older person with dementia who was being scheduled for a pacemaker insertion to manage a profoundly slow heart rate. And we found that when we looked at the medicines again, because that's one of the key things that you do, especially in geriatric medicine, is we found that the resident had been started on a cholinesterase inhibitor. And we also knew that this kind of drug causes bradycardia, or slow heart rate, that could be leading to the need for the pacemaker. And so by identifying this prescribing cascade, we were able to stop the cholinesterase inhibitor, and the bradycardia resolved, and the individual didn't need a pacemaker. So important things that maybe are happening all too frequently and we need to recognize. So this is something that started in an observation primarily from older women and primarily from older women in long-term care settings. It's now been written about by researchers from at least 16 different countries around the world. It's been talked about in original investigations. It's been described in review articles and in medical textbook. And it's now, I guess I'm really happy to say, been included in many deprescribing protocols that are being used worldwide, which are really designed to help providers identify medicines that can be stopped, particularly for older adults and women. And we've been working with investigators from 6 countries to help identify more and we've identified, I think now, more than 100 prescribing cascades, maybe approaching even the 200 range. And we're creating lists of these that clinicians can use and exploring how they potentially impact women and men in different ways. And this information will, I think, really be important for informing deprescribing protocols that are really tailored to the needs of older women and men. And also, I think it's good to see that this kind of information isn't just staying in the academic world, because it's important for the public. And these cascades have now been the subject of a book chapter in the popular book Elderhood, which has been receiving a lot of attention, and it's a great book if you're looking for somebody to read about aging. And it's also been written about in articles in the newspaper, which is really helpful to get the message out, including articles published in the New York Times. So given what I've been talking about, it's really important to think about how sex, gender, and aging needs to be thought about, and how can we translate that into improving health and wellness for older women. And here at Women's, we are working hard to lead efforts to start to understand some of the unique health needs of older women. And equity is so important here. And we're advancing equity-focused healthcare through equity-focused research. And I think a very important piece that everyone needs to remember is when you study women, you learn a lot about men. So it's really important to think about how do we look at these different groups in everything that we do. Now, we're exploring how sex, gender, age, and other very important key identity factors matter to our research and care. The example I told you about Zolpidem, the sleeping medicine, that's now got doses for women and men, is an important step forward in that direction. But we have a long way, I would say, to go to ensure that we're getting these doses customized so they're made in different ways for older men and for older women. Many drug therapies and the treatment protocols that we're using today for so many different conditions have really been developed without adequately representing older people or women. And data are unfortunately rarely reported separately for sex and age and these key identity factors, which really limits the opportunity to tailor therapies for older women and men. And this picture here shows a bunch of shoes. And I think it points out an important message. You know, when you think about it, when it comes to other industries like fashion, and in this case, fashion footwear, or personal care, or just about anything you can think about, they're customized. That's really the standard. So I guess the question is, why should we settle for a one-size-fits-all model when it comes to our healthcare? A model that results in older women in particular experiencing side effects that really are things that could be avoided. So we're taking a leadership position in incorporating sex, gender, age, and key identity factors into all the research that we're doing here. So I've described to you a little bit about the impact of not including older adults, and in particular women, in drug trials. But as I've said, this applies to so many areas. And one of the things we really need to look at is policies to ensure that older women are included in research, to inform this more tailored approach to care for older women and men across their lifespans. And I think it's fair to say that the lack of information about differences between women and men that I described to you in the drug world, but that applies to so many other areas, is largely due to their underrepresentation in clinical trials. So I'm pointing out some things here that may seem a little bit shocking, but it wasn't until 1993 that in the United States, women were required to be included in research. And so some of the measures that came forward there, like the NIH Revitalization Act of 1993, were important because they established guidelines for including women. But it's interesting that these guidelines focused on women as a whole, and they didn't make recommendations related to age. And so older women were still very much potentially missed out here. And it wasn't until just last year that older women were required to be included in research. And I think one of the issues that we have is when you look separately with policies that look at women, and you have another policy that looks at age, and they're not really intersected, that can lead to still gaps, especially for, in this case, older women. And when women are not included in research, you know, here's an important takeaway message. When women, even when women are included in research, you need to report that sex and age disaggregated data. Because without that, you can't really identify these people. So you have to go to the next step to make sure that you're counting older women. So we're working, you know, this is a huge task to get basically to shift people to think this way. And it's not something that we can do alone. So we're encouraging people in the healthcare sector who are working here, who are working across the province, across the country, and internationally, to really think about getting these key factors included in their research and reporting this information so that the work that we do is applicable to all. Now, I'd like to talk a little bit about COVID-19 and long-term care and older people. And I think you really can't do a talk about older women without talking about this. I think COVID-19 has made visible the inequities in our society, particularly those for older women. And I'm not sure that the extent to which it's important for older women is clear. But in long-term care homes, as we've said, women make up the majority of the residents. Women also provide most of the paid care for residents in long-term care. And women provide also most of the unpaid care. So families going in to provide care for their loved ones. But I'm not sure that that information is really as clear as it should be, and it's very important. Now, when we look at information that's being gathered about COVID-19 and long-term care, there's some important pieces here. One is that when we think of COVID-19 and deaths, this rate for Canada as a whole relative to other countries is relatively low. But what may not be so well known is that Canada has the highest proportion of deaths that occur in long-term care homes. So the highest proportion of their deaths are occurring in long-term care homes. So what this means is that 7% of Canada's population, which is people in long-term care homes and other kinds of homes that provide care for older people, are accounting for 81% of all of the COVID-19 deaths in our country. So a very, very high proportion. And here we see that mapped out on a chart that shows how we compare in terms of that proportion to other countries. And you can see that Canada has the highest proportion of these deaths in those long-term care settings relative to other countries, ranging from Austria, and Portugal, and Italy, and Germany, and France, and Ireland, and other places. And so this is something that I think we would agree is unacceptable and are things that we should be able to prevent. Yet, despite also us knowing that older people are the group most at risk for COVID-19 death, and this information about long-term care where most of the deaths have occurred, in some work that we published recently, we found that only 3 of 10 countries around the world with the most COVID-19 cases reported the cases and deaths by age and sex. And none of these did this for long-term care homes. So here's, you can see the different countries, those with the highest numbers, so United States, Spain, Italy, United Kingdom, countries like that. And of these, only 3 of them reported information about age and sex, and none of them were doing it related to long-term care. So this really leaves older women and the majority of long-term care home residents as being a group that's largely invisible. There's been, as you can imagine, many different recommendations that have come out and groups that have come together to look at what should be done differently for long-term care. There was a long-term care staffing study that was done by the province of Ontario. And this study was important because it was looking at the staffing issues that are so important for long-term care. And out of that group that I was part of, one of their recommendations that they actually wrote about is they said that we urgently need to address the staffing crisis in long-term care. And those were the words that panel used. And so one of their recommendations, the specific things, is we need to increase the numbers of hours of direct care that are provided to residents in long-term care to 4 hours per day. The good news is that this recommendation has been taken up, it's been supported by the provincial government, and that's going to be happening, but it's going to be happening over years. And I think we know that this is something that needs to happen now. There's also a long-term care and COVID-19 report that came from a special task force that was put out for the Chief Science Advisor of Canada. And this too had important recommendations. They had recommendations for immediate implementation and those that were looking at more of the systemic issue that were for longer term consideration. And I was also part of this group. And one of the recommendations, the immediate recommendations were important, but just to point out a few of the systemic issues that were identified. So one is that there's little priority and attention put towards long-term care. And this is a really key message because this is a problem that's been there for a very, very long time, and it's something that we've been aware of. And it isn't a new thing, and it's something that we really need to address. And those systemic issues also include looking at the built environment and recognizing that it's no longer okay to have residents in rooms where there's 3 or 4 people in a room, because we need to be able to protect the well-being of these older people. And we know, I've known for over a decade that this isn't the best way to look after older people. And Nathan Stahl's been doing some really interesting and important work to bring these issues to light. But these are very important things that we need to think about. And I think we also, when we think about long-term care, COVID-19 has really made visible the impact of inequities in our healthcare system for older adults generally, but really specifically for older women. And this isn't an issue that's kind of just over there. This is a very important issue. This is important to all of us because we're all aging, and something we all need to think about. So what can you do? So going forward, I think there's some simple things. We need to make sure that older women are counted. This means that data would be available about older adults and would make older women visible. And as we've said, when we learn about women, we're learning about men too. And this is really important. And when we do include older people and women in research, we need to make sure that that information is reported. We also need to be aware of key health conditions that impact women and impact them in different ways. So for example, heart conditions, the #1 cause of death for women. And we don't always remember that. And brain health, where women with dementia outnumber men by 2 to 1. And you need to think about these things and talk with them about your care provider. And I think you really need to ask what research is being done. And now's the time to really advocate and push for more because it's really needed. And I guess our hope through all of this is that one day older women will no longer be invisible, and that older women will be looked at separately in research, and that care will be tailored to the needs of every individual, so that health equity and health equity will be something that can be enjoyed by all of us. So that's our hope for the future. And I do want to just recognize members of and say a thank you to members of our group here at Women's. Some are in the picture and some are not. And as you can imagine, this is not a recent picture, but to thank them for all their work on an ongoing basis, and to thank the many, many, many collaborators who work with us across the city, across the country, and internationally, who do so much to help us move forward this research. And of course, to thank my family for their ongoing support. So thank you.
Thank you, Paula. What a wonderful talk. It really highlights the huge body of work that has been practice and research changing. And it clearly shows your international leadership in this field, which has now reached prime time due to the tragedy of the pandemic. And some of the statistics that you've shown across the course of your career and how this impacts healthcare for older people, particularly older women, they're pretty confronting. So we are happy to take questions through the chat function. You can raise hands or you can enter a question into Twitter. We already have, let me just bring this up. I know there was a question that came in wondering about what your concerns are related to the appropriate dosing of the COVID-19 vaccine for older women compared to men. I don't know if you've thought about this, Paula, but it's a question that somebody's asking.
I think that's again an important question. And I think one of the things we need to think about is, to make sure that those older people were also included in those studies. And I assume that that's the case. And therefore, with that, we would have information to help us answer that question. So I think that goes back to the importance of making sure that the people that are going to be using the therapy, in this case, it would be a vaccine, have been included in those studies. And that we've also included, as we've talked about, women and men, which would be the case. So hopefully we'll have that worked out when that vaccine comes forward.
And also on COVID, there was a question asking if sex and age disaggregated data are being compiled regarding COVID testing.
So that information is being compiled, but I must say it's difficult to get, and it's just not readily available. So for example, when we've been looking and trying to make comparisons with different countries, there's a whole lot of issues around how the data are being collected. For example, how people might consider, when somebody's in long-term care or not, and definitions there are different. So there's so many different things in terms of the way data are collected. It's really hard to make comparisons, which is what we'd like to do. So I think that's something where we need to do things a lot better, to do it in a consistent way, and need to think about how there could be standards that we could all be following to make this information more valuable.
I actually had a question about adherence or compliance, depending on what term you want to use, in the older population. So, it's very compelling, the research that you've done into appropriate dosing, adjustments, and the prescribing cascade. Anecdotally, I've always felt like my older patients were perhaps the patients that were more likely to actually adhere to their medications and then end up with the adverse effects. And of course, if you're in a long-term care facility, your medications are being supervised. And so there's even more likely to be actual adherence to the medication, even if you're having adverse effects. Is there any research being done looking at adherence or compliance across the ages and then sort of building sex into that?
Well, I think that's an interesting issue, because as you say, in the long-term care setting, people are giving you the meds. So you are definitely getting the meds, and I think we can assume that in those circumstances, people are adhering. But when people are in their homes, you don't really know exactly what's happening. And so I think maybe that relates a little bit to the issue we talked about in terms of things like pill splitting. One of the things about adhering to medications is it something that's sort of easy for you to do. And when people have to think about splitting their pills, that may make that adherence a little bit harder. And then there's also differences too. And I think, as you sort of pointed out, maybe in some cases, older people are more likely to be talking to their doctors and listening to what their doctors are saying. So that may impact things. But when we also talked about things like sex and gender and how that might really impact adherence to medicines, and things that maybe we don't think about that may be particularly important in the community are worth mentioning. So one is, we know that, for example, older women are likely to have lower incomes and more likely to be living in, for example, poverty, because they may not have had the same kind of financial resources. And that can influence their ability to, in some countries, actually adhere to their medications. In Canada, we're lucky because we have a system that provides those medications, but it's not always the case in other countries. And so if you can't afford to pay for medicines, and that may be more difficult for people when they're older, and maybe in some cases more difficult for women, that definitely impacts the adherence. So it's important to think about how some of these sex and gender and age kind of components can play in ways that maybe you haven't really thought about.
We have time just maybe for one more question. There's an interesting question going back to your reference to loneliness in older women. And it's being asked what strategies you or others looking at to assist with this issue that seems like a pandemic in its own right that's having a profound effect on the health of older women?
Yeah, I think that's something that we just touched on here in this talk. But I think it is so important because in this case, people are living often, as we said, individually in their homes. So it's not like a situation where everyone are grouped together and they're easy to see. This group can truly be invisible. And that's why we're actually studying it and we're looking at what some of the health impacts are. But one of the sort of simple things that we need to start thinking about are things like, for example, social prescribing. You know, how do you identify this group? You know, maybe it's when people are coming into clinic appointments or they're seeing their family doctor, and to ask questions about their home situation. And then to think about how can you think about prescribing, as we might say, ways that people can get together and can interact. You know, and right now it may be things that are taking advantage of some of the technology ways that we get together. But we need to think about how we can help connect people to community, because those sorts of connections and dealing with the loneliness will be so important to improving and maintaining health for the many, many older people in our society.
Well, I think we're right on 1 o'clock. There's a lot of questions that have been coming in, Paula, and a lot of congratulations on both on your body of work, its impact, and also just what an amazing presentation that was, how clear it is, and of course, how relevant it is to the current, as I said earlier, the current tragedy that we're seeing unfolding in the pandemic. Maybe we can just go over by just a couple of minutes. Some people will have to leave, but I've been given permission. There was just a question about why it is that there's such a high mortality in Canada compared to other countries in the older population.
Thank you. Yeah, I think that is sort of, shall we say, the obvious thing that you'd have to think about when you hear those numbers and to reflect on. And I guess in some ways it may relate to who we call people that are in long-term care. And there's some thought that people who are in long-term care in the Canadian context are older than in some of the other countries. And we know that old age is related to advanced old age is related to poor outcomes in the COVID scenario. So that's one piece that we might want to think about. The other piece, or there's many pieces, I'm sure, but another piece to think about is that the amount, and it relates to the numbers of hours of care and the amount of care that's available to older people in long-term care. And I think Canada as a country needs to look at that. And I think I alluded to that in the recommendations that came out of the provincial government group that was looking at staffing in long-term care. And we need to increase the amount of care, both from the nursing perspective and the personal support work perspective that's being provided to people in long-term care. And Canada falls below other countries in that regard. You know, some of the European countries have, much more care provided in those contexts. And I think that's another piece that we need to look at. And I think we need to look, as I mentioned, that in terms of how our homes are designed. And, the architectural piece is a really important bit of that. And having a lot of homes that are following design standards or were built many, many years ago and haven't been updated in their standards, and so still have these multi-bedded rooms is not a good thing, and we need to change that. So those are a couple of reasons why Canada may be doing worse than some of the other countries in that regard. And of course, this is a moving target. This information was available from really the first wave, and so it was around May that we got this information, and we'll have to see how things are progressing. But these are really, really important questions that we need to step back and think about. And I think it does speak to the systemic issues that are such a big thing that we need to think about for long-term care and what we need to do differently going forward.
Well, we're over time, but again, I want to not just thank you and congratulate you, but to say that I think Peggy Hill would be really proud that that you gave the lectureship today in her honor, because it was very much in the spirit of Peggy Hill and everything that she exemplified. So thank you everybody for participating today, and thank you to Dr. Rochon.